Okay, guys, we're almost ready to go. 2 or 3 more minutes. I'll just give it about 2 minutes because it's not fair to people to start early when we normally do not start early. So I'd hate for people to miss something. So we'll just give it 1 or 2 more minutes and then I'll do a little bit of housekeeping and introduce our panel. Okay. I'll just give it. Okay, so I'll just kind of start briefly. The panelists needn't come in yet, but we'll just do a little bit of housekeeping. So we're running tonight as a webinar. So those of you who are not panelists and are joining us on Zoom can use the Q&A function. If you have any questions or comments, we'll monitor that. Those of you who are joining us on our Facebook page can type comments in over there. And you might also be able to catch us on YouTube, Facebook. I think we'll be able to share the YouTube stream onto our Facebook page, so you can comment on that as well. As some of you may know, this is the 3rd event that we have done as part of our Communities for Immunity project. Hannah Shockmel, our head of digital and special projects, and myself were delighted to do this campaign, as part of really a kind of a pilot program that the Association of Science and Technology Centers, the American Alliance of Museums, the CDC, and the Institute of Museum and Library Studies Services kind of programmed. So we were one of, I think, maybe less than 50 institutions across 30 states who ran the first sort of set of programs. And so we had, as you may know, earlier on in the month, a panel called Communities in a Pandemic, and we were delighted to have out Boulder or out Colorado. We had Drs. Leanne Howe and Dr. Padraig Kirwan talking about the kind of Choctaw, Cherokee, Indigenous peoples and how those communities responded, and also how historically the Irish had responded to pandemics, particularly during the Great Hunger with fever and cholera and all that. We had Dr. Karen Sonnenlieter then give a lecture on how immigrants and refugees of the Great Hunger were kind of tarred as being disease carriers because they brought with them what was then called Irish fever or famine fever. So, the whole kind of project was to try to boost awareness, to really try to combat, vaccine hesitancy, and to really harness the trust that museums and libraries, which are among the most trusted community features, in any city, to try to leverage that position, and in a kind of a both localized but also a community outreach program. So we were delighted, to run a vaccine clinic on Saturday week, the Saturday before Thanksgiving, and we had over 60 people attend that to get a booster or in fact to get their first dose. And so that's part of what tonight's program is about. Tonight's panel are Science in a Pandemic. And so our speakers will probably be entering now. We're delighted to talk about topics tonight, that range over immunology, public health, ethics, as our panel will discuss scientific challenges and the contributions of science to this, the fight against COVID-19. Our panelists include 4 professors from Albany College of Pharmacy and Health Sciences. We've got Dr. Wendy Parker, who focuses on health disparities, Dr. Barry DeCoster, who specializes in philosophy and bioethics, Dr. Margaret Doll, who's a professor of epidemiology, and Dr. Michelle Parent, who specializes in immunology and microbiology. And so we were saying, this is going to hopefully be a sort of an introduction to the science behind vaccines, behind mRNA technology, There's a lot of misinformation that is out there, and while we don't want to kind of preach to anybody, I think it's important that we listen to experts in the field. And so, these scientists and doctors and medical health professionals who have been working on both mRNA technology, but also clinics and vaccines, there's a lot that the scientists know and have known for decades that, we in the public may not know. And it's important to note, George Washington mandated a vaccine against the smallpox, back in the 1700s. So we have had medicine and the ability to fight epidemics and pandemics for a long time. And so while this kind of COVID-19 strain is possibly new, and we see again, there's mutants this weekend or variants this weekend, it is important, I think, to let the experts, sort of speak. So again, I'm very thankful to my colleague, Hannah Shockmel, for all of her work on this project. We're delighted that the IMLS and CDC and American Alliance of Museums chose us to take part in this pilot program. I will remind everyone that it's Giving Tuesday, so if you're in the mood to support the museum, you absolutely can do that. And, of course, we have more events coming up in December, starting with our Christmas market on December 4th, which will be up at Celtic Hall at New Carner Road. So while this event tonight is incredibly important, the work of the museum continues, and we're delighted to always try to reach out to people that are not just members of the museum, but members of our wider community. And that's been one of the good things about technology, is that, through using Zoom and YouTube and all these things, we can speak to more than just members of the Irish American Heritage Museum. So I'll turn it over now to Dr. Wendy Parker, and I think the panel will kind of do a rapid fire round, of their findings and their own backgrounds, and then we'll open it up to discussion. I'll kind of maybe lead a discussion, but as I said, the participants on Zoom, please do use the Q&A function to type in a question or a comment. So thank you very much, panelists, and I welcome you to the Irish American Heritage Museum.
Hello, everybody. I'm actually going to let Michelle start because her slides are up first. So I will let Michelle start with the introductions, and then we'll go from there.
Thank you. So first, thank you for having us this evening, and we're all really happy to be here and to share, our background and our expertise to help the community. So I'm going to give everyone a very quick whirlwind tour of the history of vaccines, just hitting on some really important highlights. And then we'll talk about where SARS and the new SARS vaccine, the newest chapter of vaccine history, falls. So if we go to the next slide. So a lot of people think vaccines have been around for a while. How long is not really understood by a lot, but I can tell you the earliest information of vaccines can actually be tracked back to China in about 1000 AD, so the 10th century. And at that point in time, vaccination in regards to smallpox had been documented. And as you can see, two pictures here. The bottom one is actually a painting of someone actually inhaling the scabs of dried smallpox vesicles. So sounds really disturbing, but we knew, and what scientists knew at that point in time, is that that process was enough to protect an individual. So getting infected with smallpox, about 30% of the people would succumb to infection and die, but the process of inoculation, the risk and death with that was much lower. So we look at smallpox and we fast forward about 800 years and we come to the next slide. And what we find is that based upon information, and anecdotal information at first, we were able to determine, astute farmer was able to determine that his milkmaids didn't get smallpox. And what the individual realized is that the milkmaids actually came down with a similar version of pox that came from cows called cowpox. So Benjamin Betsy decided, so he was a farmer with lots of cows and his milkmaids never came down with smallpox, but they would have some lesions on their hands from cowpox. So he decided to take the cowpox and actually inoculate his family. And they stayed smallpox free for over 15 years. So at that point in time starts probably the modern era of vaccination and how we actually come to the term of vaccine. So a scientist, Edward Jenner, in 1796, took Benjamin Betsy's observation and then decided to take a small boy in town and actually deliberately give him cowpox to inoculate him. And then, controversial, definitely, he gave him smallpox to try to see if he would get sick. And at that point in time, Edward Jenner realized that the child was protected against smallpox. And the term vaccination comes from this process. So vacca is actually Latin for cow. And we know that the cowpox virus is actually called vaccinia virus. So we infect them with the vaccinia virus, which is similar to smallpox, but doesn't cause the same type of infection, allows us to trick the body into making an immune response that will protect against smallpox. So they're close enough that the outside of the virus can be similar, but their virulence abilities are very different. So that's where we get the term vaccine, so vaccinia virus. So if we look at, go ahead, Wendy, next one's fine. So we look at what is a vaccine. And as I mentioned, the smallpox virus and the cowpox virus was the perfect example of the trick. So we used cowpox to play a trick on the body to think the person was infected with the actual pathogen. And what that does is it produces an immune response that will protect you against future infections. And all of the vaccines that we've come across in our lives will do that. So we take antigenic material, which is material from our pathogen. We can produce that and we can actually give that to someone. And that antigenic material, proteins, will stimulate an immune response. So when we actually come across the fully pathogenic organism, we're now protected. So if we look at the types of vaccines that can be used over time, those have actually evolved also. Next slide, please. So if we look at vaccines, if you look at the very top of our graph here on the right, a live attenuated or weakened inactivated vaccine is actually what the smallpox vaccine was. So we trick the body into thinking that what it's seeing is the actual pathogen. And here we're actually giving live organisms. And we don't use these very often anymore because we have better options. But all of us who received the MMR, so the measles, mumps, and rubella vaccine, actually received a vaccine that had a weakened or an inactivated organism. One of the other options for vaccines is taking an entire organism, keeping it whole but killing it. So this is a dead organism. And that's a perfect example of pertussis vaccines that we've had or influenza vaccine that we routinely have. So the next ones are actually much more commonly used now because they're much safer. We don't have a live organism or a dead organism. We actually only have those pieces of the organism that we know if we produce an immune response against will protect us against the pathogen. And these have lots of different names. They're all very similar. So a recombinant, which means we're making it in the lab, or some type of vesicle. So the next ones are ones that we've heard a lot about recently. So the Johnson & Johnson vaccine is actually a viral vector. So scientists have actually taken a virus that doesn't replicate in the body, but it is live. And we changed the virus, put genes of our pathogen in it. So a common cold virus was used, but we've added genes from SARS, so specifically the spike protein, which is the outer covering of the virus. So that's one vaccine. The second vaccine second vaccine type that we see actually very common and most people have encountered is actually the Pfizer and Redarner vaccine. And this is where we're looking at nucleic acid. And here we're looking specifically at the presence of mRNA. So mRNA actually has the ability to make a piece of the protein, and it makes the piece of the virus. And that piece of virus, the protein, is what we mount antibodies against. We mount immune response against, and it protects us against infection. So a lot of people were concerned about using of mRNA vaccines as not knowing that they've been around for quite some time. Next slide, please. So if we look at the history of mRNA, so honestly, mRNA was first discovered in 1960. And in 1969, scientists could actually make mRNA in the lab. We can fast forward through many years, and what we find is that in the early 90s, scientists actually started investigating mRNA vaccines, and we start our work for immunology in mice. And we've been looking and investigating and understanding mRNA vaccines for over 30 years at this point in time. We know, and in the early 90s, that mRNA vaccines were used to investigate treatment against cancer and influenza. In the late 2000s, so 2013 to 2017, there are various clinical trials that have been in place and have moved forward to use mRNA vaccines as a treatment for and protection against rabies, Zika, and Ebola. They're actually influenza vaccine trials and CMV. And then in 2018, the FDA has approved lipid particle drug treatment. So why is that important? The mRNA for SARS is actually placed inside a lipid particle. The advantage of using mRNA is that it's rapid to make, so it makes it very easy, and we can make it very quickly in the lab, which is very different than all of the other vaccines that have been used in the past. The technology was already available, and that allowed scientists very quickly. So Redarner scientists worked with the NIH, Pfizer scientists worked with BioNTech, and they actually were able to develop these vaccines. And in 2020, the COVID mRNA vaccines received emergency use approval. And in 2021, they received full approval by the FDA. So if we move forward, next slide, and we actually look at what we find for our COVID mRNA vaccine. So inside this circle is our lipid. In the lipids that make up the vaccine, so Wendy, you can bring up the text. The lipids that make up the vaccine is actually lipids that we come across in our body. And some of these things you may have heard of before. So cholesterol, we all know what cholesterol is. We have cholesterol levels that may be high, maybe low, but they're a common lipid in the body. And the lipid acts as a bubble. And inside that bubble is a copy of viral mRNA. And for SARS, that viral mRNA actually codes for the protein that makes the spike that's found on the outside of the virus. When we get vaccinated, that lipid particle actually gets taken up by our muscle cells. And the mRNA is released to our cells. It does not go into the nucleus, so it never encounters our DNA. It stays in the cytoplasm. And there, our body actually takes its own machinery and makes viral proteins that get put on the surface of our cells. And that's what triggers the immune response. Our body recognizes that spike protein as not belonging to us, and it actually starts to mount the immune response. So when we actually do see the virus, we can provide protection because we responded to this fake infection. And that fake infection is just the presence of the spike protein on the surface of our own cells. So when we get vaccinated, what we find is that at the first dose, we have little to no antibodies. So in this graph here, on the left axis, we're going to find the immune response. And on the bottom axis, you're going to find time. Gray represents Johnson & Johnson, and red represents our mRNA vaccines, such as Pfizer, Redarner, or AstraZeneca. So we have no antibodies to begin with. We get a vaccine, and our antibody levels go up, and then they wane a little bit. They come down, and that's a part of natural immunity. We get our second boost. We get our second dose for our vaccines, and our antibodies level go up. And then that plateau stays even higher. And then we know, especially with our mRNA vaccines, where we've gotten a booster, so we've gotten our first 2 doses and then a booster, that titer, that level of antibody stays high. One of the other things that happens every time we get another shot of the vaccine is that we actually improve the quality of our antibodies. So one thing that's happening right now in the news, we have a new variant, and there's a lot of information about getting a vaccine or getting a boost. So even though it may not match perfectly, the quality of the antibody that you produce improves every single time we re-stimulate the response. And one of the qualities of that is that the antibody holds on to the virus even tighter. So it may not be a perfect match, but it's going to hold on to the virus and actually help to eliminate viral protein and help to eliminate virus and hopefully keep you from getting quite ill. So that's kind of our capsule of science. And I'm going to now move on to my next colleague, Dr. Parker, who will talk to you about public health aspects of our COVID infections.
Thanks, Michelle. So I'm actually a public health person and a sociologist, medical sociologist, and Michelle and I have been partnering over the last 18 months or so to run a COVID testing center on campus. And so despite the fact that I've always worked in chronic disease, I suddenly feel like I have much more knowledge about infectious disease than I ever did before. But I'm going to put the public health hat back on and talk a little bit more about some of the sort of ways in which public health cares about this, and lead in a little bit to some of the vaccines and some of the disparities, and lead into Maggie's talk specifically about pediatrics. So of the greatest public health achievements over time, vaccines are always at the top of the list. It's always, if you Google right now, I swear to you, if you Google the top 10 public health things, you will find a CDC page and a FDA page, and you will find all these different pages, and vaccines is the #1 thing on all of them. So I get it, right? We're saving lives, we're protecting people, but really it's about the millions of lives we can save with vaccines. That's why it sort of always ends up at the top. So when we're talking to students a lot, we talk about what the difference is between public health and just thinking about healthcare. It's about saving lives by the millions. And so looking at the broader ways in which we can contribute to that in society. So that's why public health cares. And the second part of it is that we also want to focus on equitable healthcare, right? So there's sort of 2 prongs that public health takes, which is one, that want to prevent people from getting sick at all, and then looking at those people who, once they do get sick, kind of what happens to them in the system, and ensuring sort of equity and social justice. I'm going to talk a little bit about both of those aspects as we move forward. So what's the public health motivation here for vaccines? So what would make someone go get a COVID-19 vaccine? So Michelle's explained a lot of this from the bench science version of this, but let's try to think about it from the perspective of sort of everybody in the public. What would make them go get a vaccine? They get vaccines all the time, right? We vaccinate our children. We get flu vaccines yearly, a lot of us. So there's a lot of belief in the safety of the CDC and the FDA and the systems and structures that are in place in the US especially. We believe that these vaccines are safe and effective. And what is different a little bit about the COVID vaccines than how we think about other vaccines is that it's going to stop you from dying, most likely. For most people, it's going to not necessarily guarantee you don't get sick, right? So there are people who are fully vaccinated who have what we call breakthrough infections, right? We're seeing more and more of them, especially with different variants. But what we have found is that those people are a lot less sick than those who don't have the vaccine. So vaccine's doing exactly what it's supposed to do, which is really reduce the severity of the disease for people who actually come in contact with it. So the other sort of conversation I hear a lot about is this, the known and potential risks, right? So we hear like the myths of, well, they fast tracked this, and so that means it can't possibly be ready for prime time, right? None of that from a scientific perspective is true. As Michelle pointed out in her talk, there had been lots of work done on the mRNA vaccines long before we ever learned about COVID. And so what they did was just sort of go faster through some of the safety checks, but not skipping any of the safety checks, right? So just sort of fast forwarded. And the way we could do that is because you're putting all of the resources onto one bucket, right? So the government normally would spend money on lots of different vaccine trials in the last couple of years. All of those resources have been kind of funneled towards COVID vaccine trials. And so therefore we can move faster than we might otherwise be able to. I think the other complaint, I don't know that I hear this one as much anymore, but was about side effects. And what I kept trying to convince people along the way was that the side effects meant your immune system's working, right? So I took my 8-year-old daughter tonight for her second dose, and that's the whole conversation we had on the way home, was that if you know, if she doesn't feel great in the morning, or if she starts to feel a little headache or anything later, that's a good sign. That means her immune system is actually working. And so far so good. Anyways. The other sort of big motivator that public health used was once the pandemic had sort of locked us all down for a long time, the sort of carrot and stick approach was to say, if you were fully vaccinated, you can go back out in public and do the activities that you couldn't do before, right? And that you should still wear a mask at some points, but that people who are fully vaccinated didn't necessarily have to wear a mask all the time. That was supposed to be a big motivator. Unfortunately for us, people are complicated and they don't always do exactly what we think they're going to do. And so they sometimes make things more complicated, I think, or we've been talking about misinformation a lot, like students are talking a lot about misinformation, but I think this is a Kaiser family poll from relatively recently, asking people, what do you think would be a bigger risk, to be infected with coronavirus or getting the COVID vaccine? Of the people who got vaccinated, no surprise, they all believe that becoming infected was a bigger risk. But if you look at the people who are unvaccinated, the switch, it flips there, right? So people, more than half of them are still saying that getting the vaccine is a bigger risk. And I think there are lots of public health scholars out there trying to figure out, what do you do about that? How do you convince people, right? How do you at that point say, you know, that's not true? And it is no longer about, well, I don't know anybody who's had COVID, because we're not at that point anymore, right? There's enough COVID cases around that that's not true. So how do we move beyond that? And I think we don't necessarily have all the answers yet figured out. And with that, I want to take a little bit of a step back to also say that, because as we start to think about sort of the disparities and who's getting vaccinated and who's not, that we still remain in the lucky part of this equation right here in the US, right? So on a global rollout of COVID-19 vaccines, only 50% of the world population has had one dose of a COVID vaccine. Well, there's been almost 8 billion doses administered globally, and 31 million are now being administered daily. Only 6% of people in low-income countries have received one dose. And I think this chart sort of puts it all in perspective a little bit. So the darker green is looking at the share of people who are fully vaccinated, and then the lighter green is the share of people who are only partially vaccinated. And what you look at this is sort of a map of the first world versus the third world, or the haves versus the have-nots, or however you want to look at it, right? Those of us who had resources to buy the vaccine early on were able to get vaccinated at higher levels. And the countries towards the bottom of this chart, I mean, so if you look at, it's not even countries, these are continents in some cases, but if you look at Africa at the bottom there with 7%, right? So that isn't because people didn't necessarily want to be vaccinated, right? So these are two separate, we're sort of putting together these two separate issues of who wants the vaccine and who has access to the vaccine. And I think that's where public health maybe needs to do a little bit better job of sort of disentangling those two problems potentially. So this, I know that graph on the right is probably going to be hard to read, but I wanted to talk a little bit about the US-based disparities as well. So we talked about it as a global issue, but truly in the US, race and ethnicity has contributed to the disparities we see here as well. And so the graph on the left looks at the total percent of the population that has received at least one dose, and that's really current through like a couple weeks ago. And what you see is percentages all hovering around 50%, with the Asian population slightly higher at 72%. And then trying to sort of disentangle that a little bit more to figure out sort of what really is it, like where are the gaps in vaccine uptake, so that we can try to target those groups, right, to sort of move in that direction. And so if you look at the graph on the right, the dark blue is the group who's already received one dose. And so what you see there is the people who are at or less or around 50% are rural residents, people who are uninsured but younger, white evangelical Christians, adults without a college degree, lower income people are sort of all in that same kind of group. And so what does this leave us with as sort of public health and sort of strategies for how to attack this problem, right? So if you're listening at all to the news these days, you've heard about these sort of upstate New York clusters, right, for COVID. That would be the argument for rural residents, right? So that there are pockets throughout upstate New York where people are just not getting vaccinated at a high enough rate to stop the spread of the virus. And then those people are traveling throughout the state and elsewhere. And that's what's helping to contribute to these sort of rates that are going up for COVID cases everywhere. So my last little picture is to just sort of say, this is a highlighted in on Albany in the capital region. This is showing a 5.8% positivity, test percentage positive in the last 7 days. And it ends as of yesterday, I think, or no, Monday, 28th. So just to give you a sense that number probably was hovering around 3.5% for most of the fall and has sort of jumped up as kind of expected as we all move indoors and as we want to gather for events and we start to travel and all of those things that happen. What's also happening and that we've noticed a lot of and what changes some of these rates is people aren't getting tested anymore unless they've been exposed or are really sick. Tests aren't available in the same way. And so that's sort of changed the models of how we look at these numbers a little bit as well. And I'm going to leave it there and turn it over to Dr. Maggie Dahl.
Thanks very much, Wendy. And thanks for having me here tonight. It's a pleasure to be on this webinar. I'm going to switch gears a little bit from my colleagues and talk about kids. And specifically, I'd like to give some history of pediatric vaccine mandates, some recent history about pediatric vaccine hesitancy, and talk about how this might relate to COVID-19 vaccines in our vaccine programs. Next slide, please. So I guess to start off with, why am I talking about kids and pediatric vaccine programs? Aside from this being my area of research expertise, I think we can actually learn a lot from our COVID or from our vaccine programs that have existed among kids. To date, we are vaccinating, new birth cohorts of children each year with up to 14 vaccine antigens by the age of 2. And we do a really good job with it. And we do so through school and daycare entry vaccine mandates that exist across 50 US states, as well as the District of Columbia and all US territories. In fact, we do so well that by kindergarten, only 2.5% of US kindergartners have registered a non-medical exemption to vaccinations. And so a non-medical vaccine exemption would mean that their parents are objecting to that child being vaccinated for a particular vaccine due to either personal beliefs or religious beliefs. Another reason that it's really important for us to talk about kids is when we talk about COVID transmission, they make up 22% of our population, right? So if we're going to talk about actually curbing disease, then it's really important to understand what's going on in kids with regard to COVID vaccine and vaccinations. So I just wanted to provide a brief history of US school entry vaccine mandates as they pertain to kids. Really, in this population, vaccine mandates are not anything new. The first school vaccine mandate existed in the US in 1850 in Massachusetts, and by the turn of the century, there was nearly half of US states that had smallpox vaccine requirements for school children. Our US system and states really began to take a harder look at the existing legislation that they had in the 1960s when we got more serious about curbing measles and polio, and we're finding increasing measles and polio outbreaks at schools. And this actually prompted New York State in 1966 to review its current regulations and pass a school entry vaccine law that allowed religious exemptions for people who did not want to get vaccinated. They were able to request an exemption from vaccination due to sincere religious beliefs. And this, the reason I highlight the New York State law is because it actually was used as a template for many of the sort of current iterations of legislation that many states have across the United States. And by the 1980s, all states had school entry vaccine laws, and all but 2 at that point in time permitted some sort of non-medical exemption, whether that be a religious exemption or a personal belief exemption. So next slide. So these school entry vaccine mandates and daycare entry vaccine mandates have done a really good job of assuring and maintaining high pediatric vaccine coverage for a range of vaccines in our population. Over the past couple of decades, there has been a small but significant uptake in non-medical vaccine exemptions. And so we know that because of some of these diseases that we're vaccinating against require very high vaccine coverage in order to maintain herd immunity in our community, that even these small decreases in vaccine coverage can lead to vaccine preventable disease outbreaks. And such is the case of measles. So measles is a disease in which it's very transmissible. There must be about 95% coverage of vaccine in the community in order to maintain herd immunity. And what we saw in December 2014 is that there was a large outbreak because we began to see sort of these upticks in non-medical vaccine exemptions. And so next slide, please, Wendy. So as you can imagine, an outbreak of measles that originated at Disneyland was quite sensational, and many of you may sort of think back to this time period and may remember the news stories that were circulating at the time. But what really this outbreak did over a period of several months, while the outbreak spread to 22 states with more than 150 cases nationally and more than 100 cases abroad in Canada and Mexico, is it shined a light on vaccine hesitancy and made it a national issue in the United States. And it really, from both the media and also from social media, a sort of pro-vaccine narrative really emerged from this event. And next slide, please, Wendy. So much so that in 2015, California actually was successful in repealing its non-medical vaccine exemption from its existing school entry vaccine laws. And this bill was proposed shortly after the Disneyland measles outbreak began. And it was really sort of galvanized with the momentum of this pro-vaccine movement, and it was able to pass through the legislature. And so, next slide, please, Wendy. So as you can imagine, that the anti-vaccine and vaccine hesitant communities were really upset by this legislation, and that resulted in a sort of this backlash to this pro-vaccine movement. And actually, if we start looking at social media discourse around this time, what we found is a different narrative that was emerging with regard to vaccine hesitancy and anti-vax messaging on social platforms. And so, Wendy, if we go to the next slide, what this shows is a Twitter network analysis of relationships between Twitter user groups before and after this California legislation was proposed. And so on the left, what we're looking at is three sort of distinct groups of Twitter users. The pink here is sort of Twitter users that focus on sort of anti-vax messaging. The orangish color is Twitter users who focus on autism, and the green group here is Twitter users who are identified as socially or politically conservative. And so this separation that exists between this green group and the anti-vax and the autism group, and before the SB 2787 bill was proposed, shows that there wasn't a lot of discourse or sharing of tweets between these two groups prior to this legislation. But actually, once the legislation was proposed, what began to emerge was a new narrative where some sort of the discourse in the anti-vax communities changed to discourse surrounding vaccine choice and framing of vaccinations as a civil liberties issue. And once that happened, this was also sort of the era where the Tea Party was very politically popular among some factions at this time. What we began to see is a lot of sharing of tweets and a lot of discourse being shared between conservative groups and anti-vax groups, with probably this sort of rise in this narrative of vaccine choice and civil liberties. Next slide, please. So why is this relevant to the current situation with regard to COVID-19 vaccinations? As Wendy pointed out, if we look at people who are not getting vaccinated, certainly we do see a large division with regard to political party affiliation. And while I in no way want to presuppose that vaccine hesitancy is monolithic, there's many different sides and many different reasons for vaccine hesitancy. What we do know is that when it comes to getting COVID-19 vaccinations, political party is a huge predictor. In fact, I think among Democrats, what I had recently seen as of October, 92% of Democrats who identify as Democrats had received a COVID vaccine, whereas only 56% of Republicans had. So we see this large ideological divide between these two sort of political sides, and potentially this can be traced back to this sort of moment in time. So I just wanted to conclude by just sort of thinking about pediatric COVID-19 vaccine uptake and identifying where we might be at now. The map on the left looks at state vaccination rate for children ages 5 to 11. Obviously, this is a group that newly can get vaccinated. I'm excited that my 5-year-old just got her second dose over the weekend. And so the patterns that we see here, while vaccine uptake at this point in time is not very high, the patterns that we see here emerging both between children ages 5 to 11 and then also children ages 12 to 17 who've been eligible for vaccination for some time, I think are largely similar. And they're largely similar to what we're seeing as well with regard to adult vaccine uptake, particularly if we look at the Northeast and the West Coast, we see higher uptake, whereas southern states or the Mountain West, we're seeing lower vaccine uptake. So where are we going in terms of pediatric COVID-19 vaccine mandates? California's governor recently announced that he planned to mandate COVID-19 vaccines for all students as soon as next fall. Really, I think, if I were a betting person here, I think as soon as these vaccines have received full licensure in pediatric populations, we may see many states actually joining suit and deciding to mandate pediatric vaccines as a part of their school entry or daycare entry vaccine requirements. At that point in time, I don't think that many states would view COVID-19 vaccines as much different from many of the vaccines that we're currently mandating. And certainly our governor has said that, vaccine mandates is an option at this point in time. So thanks very much, and I'd be happy to answer any questions about this after Barry's talk.
So hi, folks. My name is DeCoster. I'm a philosopher by training. So the next few minutes, I just want to kind of give a quick overview of a number of ways about thinking of the ethical challenges. So not the sort of science or the public health beginning point, but ways we've been thinking through, like, what are the moral and ways we want to respond as individuals and as communities, maybe that's as governments. I am also, much like Dr. Doll and Dr. Parker, I am also part of the Population Health Sciences Department. So we kind of all have been working together in a number of ways the last few years, and it's been kind of fun to, so thank you, Elizabeth, for inviting us tonight. So Wendy, next slide. COVID kind of hit really fast and really scarily quickly, right? One of the interesting things was it was a brand new virus. And I think that was one of the things for a number of us, that novel virus, or the idea of that we had a whole new vernacular, a whole new set of words coming at us really quickly. It felt like in many ways, because it was new, we didn't know how we were supposed to respond in these moments, right? We know about chickenpox. If we're old enough on this panel, right, we all had chickenpox. The rest of us probably got vaccinated by chickenpox. That's at least a ritual that we understand how to move through. And so in that way, that one felt safe. We knew the kind of ways to move through that world. This scary new virus went really fast and kind of went global, right? Thus the definition of pandemic. And that was part of the worry. I think in many ways, it started off a number of set of fears. It was both the individual health risks that we were facing, our family members and friends were facing, but also we just didn't know necessarily how we were supposed to respond in that. And so people got kind of torn up and confused by a number of things. Right? We had public health updates. We're regularly, almost daily, if not weekly, certainly, we're being updated with new information. People were struggling to kind of keep up with the facts, how to produce also new understandings about how we were supposed to respond, and how to develop new habits, right? 2 years ago, I bet most of us were not regularly wearing a mask. And now I think it's a habit for most of us to walk outside, go to the grocery store, we throw a mask on. I've got one in my pocket. I've got them stashed in my car, in my glove compartment, and in my school bag, right? I've got masks everywhere. And I've watched my students do this. And I've also, like, for the folks on this panel who have kids, right? Those little kids have figured out how to wear masks regularly. So we got new rituals. And then there were questions ultimately of like when it was, like how effective that mask was, but also who should be wearing them when, right? And there was this hope that maybe we could get rid of the masks as soon as the virus, we got a vaccination campaign underway. That hasn't quite worked out that way. So one of the issues here of like how to act well was this as a topic seems like it's brand new. What I want to point out in the next few minutes here is to say we have resources. Some of them are ways of traditions and habits that we figured out in prior health issues. Public health has developed a number of situations, and bioethics, clinical bioethics, has also given us answers. But then there are some things that are new, and some things that are worth figuring out, and some things that I would say are still open questions. So with that, mostly what we're going to think about is like who's ethically responsible. Yeah, Wendy can go on to the next question. Yeah. So for my discipline, bioethics, maybe one of those things that you've heard about, but no, unless you've been lucky to work with a bioethicist like the people on this panel, you may not know exactly what they're doing. So bioethics can be done from a number of different positions. I come at it from philosophy, right? I went to graduate school and was trained as a philosopher. You can do bioethics from a number of other ways, though. Religion, law, the rest of the humanities can all sort of talk about how health, how medicine should be responding appropriately. The social sciences, the clinical sciences, and the bench sciences are all also have ways into doing sort of best practices around medicine. So while I was trained in philosophical bioethics, I also did a postdoc in a hospital, right? So I was the person kind of going, attending to patients at the bedside, working out when there were disagreements between a physician and a patient on how the right thing to do was. So Wendy, if you can hit the slide maybe 2 more times. So ultimately, ethics is trying to respond to this like really old question: how should we act well, right? What should we do that is the right thing to do? So for me, I say the word ethics. Many people might use the word how do we act morally. For the moment of this slide, I would say treat them interchangeably. I steal this definition at the bottom here from Martin Benjamin and Joy Curtis. I say ethics is what should be done in a given situation with all ethically relevant things considered, and then why. So those 2 highlighted phrases are kind of important here. we need to ultimately act. We can't be paralyzed in fear. We can't stay in our homes. So we need to know what to do, but we need to sort of filter through what are the sort of conditions that are ethically relevant to making a decision on how to act well. And then we need to be able to give a set of reasons. This is the reason we are choosing to act in this way, even if reasonable people can disagree. We can explain that to others and make a case for it. If we listen to others, they may change our minds ultimately on what we think is the right way to act. Okay, so Wendy, next slide. Clinical bioethics is probably what most of us understand my discipline to be, the doctor-patient relationships. That's the stuff that has either been reflected in, say, TV and movies the most. It is the emphasis there is placed on what is the best interest for the patient at hand. So mostly this is a kind of one-on-one situation. Sometimes we have moments where family members are involved, but even then, we're really trying to sort of think through what does the patient need here most and foremost. When Maggie brought up, that her child has just been recently vaccinated, right? That's a moment where we're trying to figure out what is it needed for this kid in this moment here. Other forms of bioethics, though, kind of expand beyond that. We have clinician-clinician relationships as another moral relationship where, say, doctors and nurses have to interact and they disagree in certain moments. Bioethics might resolve some of those tensions there. We also think as a bioethicist a lot about healthcare policy, how to sort of write good policy that is going to be important to sort of individual health, but also public health. In those moments, again, just to make this real clear, because that's the contrast, clinical bioethics is almost always about what is best for an individual. There's other domains, though, that are importantly related, but very different out of public health bioethics. In those moments, we're usually thinking not about what's well-meaning for individuals, but for communities. In public health bioethics, it's almost always based in utilitarianism or a kind of cost-benefit analysis for what is best interest for the group that we're talking through here. So that could be sort of what is needed for the adults in the Albany area. It could be as specific as, what is needed for individuals who identify as women who are 80 years older or above, right? We can get really specific with what that community means. It might also be, what are we going to do for all children in the United States, right? That's a kind of public health approach that we talked about earlier, where we've had really good vaccination success. Here we have a tension, though, again, between individuals and communities. No, you can keep going. So some of the debates that were kind of raging over the last year, and we've kind of addressed some of them in popular culture, and then we kind of moved on to new ones. A lot of the emphasis this last year was once we had a viable vaccine and could kind of get it distributed, we had a tension here. One was, and I gave you some reading if you want to kind of go back and kind of read more on this. Who should get a limited issue? Sorry, let me start that over. If there are limited supplies in the first wave of given vaccinations, right, who should get it first? So there was a debate. Should it go to healthcare workers who are frontline workers, right? The people who are addressing and kind of keeping them healthy so they can give greater services out to their patients? Or should we give it to the highest risk? That largely became folks with largely older folks and others who are in healthcare high risk populations. So in this New York Times article, there's a kind of longer discussion there. And there are pros and cons. One was about sort of preventing deaths. If you kind of gave it to elderly folks first, if you gave it to essential workers first, you were preventing spread. And what we wanted was both ultimately, right? But if you only had the sort of first few vials of that to give out, who were you going to prioritize and why? The second reading that I gave you there is from Zeke Emanuel and a few others who were trying to say at a global scale, what we did was here in the United States, we really did hold on to a lot of vaccines rather than distribute it globally first. And they don't actually call the United States out quite as bluntly as I wish they had, but they make a really good case of saying what we in the United States did was sort of prioritize our own health of our citizens first, rather than worry about other countries that didn't have a public health infrastructure that could kind of protect them. Here in the United States, we actually, even though prior to having a vaccine distribution program, we were doing really well. We had ways of sort of managing the spread of this that was working. There may have been a moral or ethical claim that other countries had to the first doses of these vaccines that would have been greater than for the United States. Now, politically, that might have gotten certain governors or the president sort of kicked out of office out of public rage. But in a sort of moral sense, there might have been people who needed this vaccine that weren't outside of the United States before us. Next slide, please. Here I want to plug the work of a former colleague and friend of mine, Maya Goldenberg, a Canadian bioethicist who I went to graduate school. She had in the pipeline right before COVID was coming out a book on vaccine hesitancy. She was really looking at a prior case of the MMR vaccine in what so in the 1998, I believe it was. There was a published paper that said the MMR, measles, mumps, and rubella vaccine was connected to autism increase in children. That paper got a kind of lot of uptake. Turns out the data was really bad in that, right? There's a whole, it was pulled, there's a fraudulence claim connected to it. But the thing is, that one paper had a huge ripple effect, right? So it came up a couple of times in this presentation already. We've used different words. Anti-vaxxers became a kind of coined term. And the worry was because many parents especially didn't want their children to be at a higher risk of autism. They said, well, as a herd, as a community, measles, mumps, rubella are really, really rare. So why should I put my child at a higher risk of developing autism when they're not going to get these other diseases because everybody else's kids were already vaccinated? Well, there were a couple problems there, right? One was this paper was based on bogus science. It was faked. It was withdrawn. And then the other thing is, if everybody tried to prioritize the health of their kid and not get them vaccinated, then ultimately we go back to a pre-vaccination situation, right? And so everybody's at risk again, including adults. So part of public health was to say that we are vaccinating our children in order to protect not just them, but us as adults. So one of the good things I think Maya does in her book, and I haven't quite finished it, I'm about halfway through it, but she does sort of say, instead of talking about anti-vaccinations or anti-vax language, she tries to really emphasize this word about vaccine hesitancy. She says it's not always that people are worried about or don't believe in vaccinations. They are instead mistrustful. So she really is emphasizing here, it's not a failure of information. It's often a failure of developing trustworthy moral relationships, whether it be between a doctor and their patient, or between, say, governments and their citizens, between vaccination distributors, right, and the people who are buying this work. So the worry is, under Maya's analysis here, that we are really kind of lacking in trust around medicine, and that's where we need to. We may not fix the public health issue with more information only. We need to work at the moral issue of developing a trusting relationship. And the other things on the right-hand side of this slide, if you ever want to go back, are some other readings that I would recommend. Wendy? So if we've already kind of had, say, two big pushes in both clinical and public health bioethics, which are two different approaches, I would say that one other interesting thing that's come out or been really publicly emphasized is a lack or a gap in our way of doing bioethics. I'm calling this lay bioethics. I think this is the stuff that people were doing probably in the last week at the Thanksgiving table, quite frankly, how we are making ethical decisions around healthcare. And we're doing that, but at the individual or lay, non-expert positions. It's not doctors telling us what to do. It's not the same stuff as what public health policy has required us to do in order to, say, go to schools. We are ourselves as citizens in the United States paying attention to how public health and this COVID situation has changed our lives, right? We've all been required to make really complicated choices about what we want to do in sort of moving through the world. So some of the questions here is like, what does it mean, or how can bioethics itself support these decisions? So I put a number of questions that I've been sort of thinking through and talking through with my students even, right? So how do we as non-clinicians become informed enough to make good moral choices, good ethical choices as non-scientists, as non-medical experts? All the parents out there have had to make a decision about whether or not to vaccinate their children on COVID, right? That counts as a sort of bioethical issue, but most of us will not be trained up as bioethicists. We are requiring to face these complicated decisions about how do we protect ourselves, how do we protect others in our family, our friend network. And then the other really complicated thing here is that third bullet, I think, what are we supposed to do when we disagree? Like, that's its own ethical issue. Like, we have understood maybe how to take care of our family, our friends, but when our family and friends, extended circles, disagree about that, right? That's when you get this clash of sort of maybe who has vaccinated and who hasn't. We don't really have good language yet, I think, as a culture to think through these issues as health issues. And there are some resources bioethics can provide here, some language that, but again, clinical bioethics was really about, what do I need as a patient? We need better language here. All that is some ways about handling our immediate social relationships. But I would also say what we need is better language and better new rituals for pushing policymakers, right? People in government to make better policy that we can be involved in as lay folks, as non-experts, but to sort of get our needs, our worries addressed and heard so that better policy can be made, right? So how do we get ourselves seen as voices that are centralized in making better healthcare policy? So I'm just going to, I rarely ever get the chance to do this, so I'm going to do it. Some of this is something I wrote about 15 years ago when I was right out of graduate school. The worry then was the bird flu as a sort of global possible pandemic. That one actually sort of faded out in a number of different ways. But in that, I tried to make in this article that I've cited here, a push for saying what we really need is a better set of rituals for us as one, having developed language to understand that we are, as citizens, making bioethics decisions all the time. We need guidance, and we need to recognize that that is work that we are doing. The second thing in that article I tried to point out is we need better recognition, not just to protect ourselves, but also to make sure that policy gets informed and written and passed ultimately that is reflecting the values that we have. And so far in the United States, I think that's been one of those interesting things. We see that a lot of the conflict there, but we haven't found a good way for having all of us kind of write to the folks in charge and get better healthcare policy passed. So we're kind of hoping someone takes charge, but I think there's a way in which we need to find ways to empower ourselves to make sure our voices are heard. So with that, I'll stop and hand things over to Elizabeth. So thank you.
Well, thank you guys. That was absolutely fantastic. I was not sure, you've answered a lot of my questions. So I definitely want all of you who are on Zoom with us to, pop a question or a comment into the questions and answers feature here, and we'll monitor YouTube as well. But I suppose, thank you for breaking down the science for us, Michelle, especially those of us that are scientists. Maybe if you wouldn't mind just kind of commenting, whoever wants to answer it. I suppose the problem is, what Barry just finished with, and Wendy, you mentioned it too, the carrot and the stick, and so how do we balance a carrot and a stick in a society where there is, and I can't remember, was it your presentation, Wendy, too, that talked about, remember in those early days, like we didn't have enough equipment, so that was why they were telling us not to use masks, because we had to keep them for the healthcare workers. The messaging seemed to change, and I suppose that's a lesson for those of us who are not scientists, is that science is not, finished, like it's not, we know everything now, and it's a truth, that's the whole beauty of science, like that it is constantly evolving. And so, when you have not only the experts, I won't say being shaky, but like changing as the situation changed, and then maybe you had, politicians who admitted that they didn't want to create panic, so they weren't maybe fully transparent about what was going on, coupled then with hesitancy on both the left and the right, and sometimes this is maybe, Barry touched on it, that like ethically or financially, maybe Big Pharma did not share vaccines with poorer continents. Is this a question of money, or is it a question of intellectual property, or what is it? So how can we meld this carrot and stick so that, the world can come together as a community? That's a huge question. So I don't mind which one of you wants to answer it. So I guess I should say, what's our priority going forward? Anyone, yeah.
I hesitated. Go ahead. Yeah, I thought Maggie was too, so I was waiting. So go ahead, Maggie.
I was going to, I don't know what the answer is in terms of the world, but I was going to say, with regard to the carrot and the stick, when I think about pediatric vaccine mandates and school entry vaccine mandates and daycare mandates, I think about religious or personal belief exemptions being sort of, I've heard them described as a pressure valve release in a system, right? So we know we have these sort of opposing factions potentially, or some people who feel very committed to or unsure about vaccination. And so how do we release some of that pressure in a system that really has become very polarized, particularly in this debate? And if we potentially have this capability for people to sort of climb out of the system, but do so in a way that not everybody is climbing out of the system, right? So if we're going to have exemptions, to have them in a way that is strict, and it's difficult to actually go get an exemption. Maybe you have to take a 3-day course and really learn about the science of COVID vaccines and make these conscious decisions. But if we have that in the system, then potentially we're not at a point of explosion. And so when I think of the carrot and the stick, potentially I think of that as sort of like a way of potentially balancing that, at least in a school entry vaccine mandate kind of guys.
Barry, were you going to say something? And Wendy?
I think one thing that was fascinating is we've all adapted and we have developed a way forward in this kind of unprecedented time, right? And I think that is how, it's a weird way to say I'm hopeful about that, but I guess I am hopeful. Like we've handled it, we've learned a lot in a way that everything else was sort of so far has been theoretical or hard to predict what we would do. This other scary thing is history has told us pandemics happen, right? And there will be others. So I don't know when the next one will be, and I don't even know how this one will end, but I'm hoping we'll do a few things better the next time and a little faster. There's just this, I also hope that we don't kind of, even if we get at sort of a high level of vaccination, I think there are all the questions that we're still going to have to grapple with was like, how did this one come about in some real ways, right? We're going to have to think about global development. We're going to have to think about international trade. And like this, we've just kind of hit a whole bunch of really messy, complicated issues here, and they're not going to be solved quickly, but we have the beginnings of conversations, and it's being taken seriously and seen in a way that maybe was, I guess, more hypothetical, more up in the air only 5 years ago for many folks, right? Epidemiologists have been worried about this stuff for years, trying to raise the alarm. Now, at least I think the world has kind of gotten it. I hope there's not this quick issue, a demand to kind of go back to the way it was. So if we can kind of have these conversations and kind of engage them and still maintain the sort of complicated, hard questions and work through them, we'll be better off.
Michelle, maybe you can comment on, is it worrying for us that we do have these variants now? Is there going to be a moment where maybe the variants outpace even the fact that some of us are triple vaccinated? Is this a danger, like that the mutations will get stronger than the vaccinations, or do they just rejig the vaccine? Like, is it going to be like a flu shot, where you kind of hope it's going to cover you?
I think once all of society can be vaccinated, I think this will turn more into like a seasonal influenza response, where each year the vaccine will be tweaked a little bit and will roll out. So, if you've been paying attention to the news, the Omicron variant came out this past weekend. South Africa identified it, I believe, on November 24th, and very quickly we've identified it in various countries around the world. People were hesitant about vaccines. One of the questions that just got posted is, what do you think is the biggest accomplishment? And that's the vaccine rollout. So, we as science So, science has changed and people get angry who don't understand the science that we keep changing our mind. It's like, no, science learned more. So as we learn, we modify. And I think one of the things, we've learned a lot about mRNA vaccines. One of the beautiful items about mRNA vaccines is that they can modify the mRNA very quickly. Pfizer has already said they think within 60 days they can modify their vaccine and start to look at a change in the spike protein that would cover the changes found in the Omicron variant. The variants are a concern, but this also goes back and touches on several items that, everyone has brought up, especially Barry. We talk about, and Wendy talked about it, the United States did a really good job of taking vaccines for us. It is now the responsibility of the entire world who has the ability to acquire and purchase vaccines to vaccinate those who cannot get a vaccine quickly. We're in this together. And I know a lot of people don't like the fact that we are a global society. That's been, a difficult point for many people, but we're all in this together, regardless if we're sitting here in upstate New York or you're in Botswana. We're a global society. These things travel, and as long as huge swaths of society are not vaccinated, variants will circulate. And every time the variants circulate, everyone gets put at risk. Scientists think that even though the vaccines may not work perfectly, there will still be some mechanism of protection. So one of the things I mentioned, every time we boost, we make the antibodies better. They actually hold on better. If you think of it as a kind of a lock and a key mechanism, they may not match perfectly, but they hold on even stronger. And they think that will provide still some modicum of protection. But, as long as a lot of people are not vaccinated, we'll still see variants and they will come up much faster. So, it's a societal response.
It's just such a pity that, politics kind of gets involved with something that really we should be leaving to scientific experts like our medical experts. Patricia wanted to know, what can we tell people who will not get the vaccine because they're afraid of the effects on the body in the future? And that's something that you hear like that, it's something that they're doing to you now, that in 10 years time, you won't respond to cancer treatment or something, whatever the new thing is. So how do you combat that kind of hesitancy?
I think Michelle and I encountered this one a lot from there was a very early article that came out and was disputed very quickly, but it left a glimmer of some sign that there might be fertility related problems for young women, specifically with the mRNA vaccines, I believe. And I can't tell you, I don't even think I can count at this point how many young adult students we talked to over the last year and a half trying to tell them that article was false and that there is no data that says that. Those are the kinds of things that stick, I think, in the way in which sort of where people get their news, right? Like these are the conversations we're having with our students now, is, where do you go for your scientific information? Instagram and all sorts
TikTok.
Of places. Yeah, and TikTok. And I was like, okay, but I'm not that's not gonna work for me. So, we have to figure out some different ways. I think public health is maybe not so great sometimes at evolving their messaging that way to try to get to the heart of it. Because they don't want to offend people, right? Like we're definitely a little trying to be too neutral and too sort of in the middle. And I think sometimes that what we want them to do is actually take a stand and say, this is what the science says, and this is the result of that.
And am I right? Go ahead, Barry. Sorry.
One other little thing though, like there's something interesting, and I guess it's been bugging me throughout part of this presentation. This has been a good success. We had a vaccine, right? And people are refusing it. And I guess that's a question. But I will say that, okay, I'm a middle-aged gay guy, right? I grew up and sort of as AIDS was kicking in, and it decimated my people's population. There are infinite number of guys who are not here, who should have been either my colleagues, my mentors, older guys who I should have had crushes on, right? They died because governments ignored the reality of a disease. there was something different about here. Whether or not we even had the vaccine, we had a discussion about the vaccine. And in some ways that's good. And then part of what Wendy, by bringing up the fertility issue, kind of the thing that grates me is, well, now it became about my baby and something about the people who I wanted to protect for things that I was worried about, right? My daughter's fertility. Then people cared, right? But it did sort of interestingly, as a contrast, right? Sort of say, like, when AIDS was kicking in as a vaccine, there were whole communities we didn't care about, and so we just ignored it. And that's still going on. We have some medications that will prevent new HIV infections, but they're not being used nearly to the extent that they should be, right? We have other public health failures that are kind of parallel to this, and that's scary. Like, maybe the mRNA thing will kick in and we have some interesting possibilities about HIV vaccinations, but we've been saying, it's 10 years down the road since the 80s. So there's interesting things about like what's working and what's not, and what we're valuing and who we're even kind of worried about.
That came up, Barry, in the other panel that we did with the communities. And actually it was interesting because, I had read anecdotally that, for instance, like the LGBTQ community were like, oh, woohoo, there's a vaccine. We've lived through this before. Absolutely, we want to get inoculated. And there is also hesitancy among some of the community because they thought, well, hang on now. It took you years to come up with something for HIV. So how come you got this so fast? And so it's just, amazing that it can work, kind of both ways. I think what I was going to say about the science and what you tell someone, about being afraid to put it in their body. Am I right in thinking that, the mRNA sort of like melts out of your system, that, like you said, Michelle, it doesn't go into your DNA of your cells, like it doesn't transform you, so yeah.
So the mRNA lasts for a very, very short period of time, days, if that. The protein that it makes will be on the surface of the cells for a few weeks, it's thought. But so our genetic instructions are held in DNA, and the DNA is inside the nucleus. The mRNA never gets into the nucleus. It can't integrate itself into our chromosomes. It never makes it to the area where the DNA is located in the cell. So, mRNA, RNA in general has always been very unstable. One of the great things about these vaccines is that they could figure out how to stabilize the RNA to last long enough to generate the protein, which is a feat of science in itself. So, it doesn't have the ability to hang out for very, very long. So hopefully, when people learn more about it or become more comfortable, I think the newness, people get very concerned that all of these corners were cut and, safety wasn't done. And that's not true. The same amount of clinical trials, so the different steps, they were all done. The reason why it was done so quickly is because there were so many people available who were exposed. So if you look at one of the other mRNA vaccine trials, there's one ongoing for rabies. How many of us know somebody who's had rabies? Nobody. And because of that, it's taken a really, really long time. Barry, was that a hand?
I know it, Barry. Bitten by a rabbit dog somewhere.
So almost no one comes across rabies, so they can't get enough people in that trial to make it go quicker. I mean, Johnson & Johnson alone screened and put almost 44,000 people in the trial. Pfizer and Redarner were up in the double digits of thousands also. So just the sheer number of individuals who went through safety trials before this was even provided as an option, that number usually never is hit when we do vaccines. And that was and because the mRNA technology is quick and available, that was, one of the early questions is what is our biggest accomplishment is getting those vaccines out as fast as they have been able to do. I think.
Yeah. Meg asked Barry, what sort of questions would you ask a person struggling with the individual versus community ethics of a situation?
Responding real fast to Michelle, I probably raised my hand too fast. I've known a number of people, like I was thinking of that through exposures to rabies, like serious.
Okay.
Exposures. Yeah, but I guess, no, probably not developing.
Not actually frothing at the mouth.
Right.
Yeah.
As for individual, for community, there is a sense in which one of my colleagues, somebody not on this panel, but came into my office and wanted their booster. And she's like, I want it. She was eligible for it, but she also felt guilty about saying there are people around the world who don't have access to it and they should. Like, that's a weird moment. And I think she's right to say, yeah, other people have a stronger demand, but also, even if you refused it, that person is never going to get your sort of vaccine, right? So that was a sense in which the right thing probably was to do is to get vaccinated, protect herself, and then also write to everybody, every politician she can get a hold of, right? And say, we need to make sure this gets distributed globally quickly. I think we have the individual or the sort of local understanding of how to get vaccinated. We have those habits, those rituals, and so we know what to do in those moments. I think part of what we need to do is to start thinking broadly about, say, the big picture issues, like how do we distribute fairly? And it's not going to be about sort of American necessarily first in these moments. We're going to have to think through like why that wasn't already the case in prior situations. What can America do to provide public health resources to other countries, right, that need it because they don't have the infrastructure that we have? I don't know. We also still have to maintain that conversation about how to convince others to get vaccinated here in the United States. But I think that's the one that's become sort of the political narrative that I've heard a lot of most recently. I think starting to think through like how we as Americans are global citizens and need to really support others is the important thing to do. And there's not an easy answer to that, right? Just like as Michelle was pointing out, science evolves and its understanding, and we need to keep up to date. Like, we do the best we have with the evidence before us. So I would say that's where science and philosophy overlaps in its methodology really easily. We take what we have in front of us. If something changes, we update our answer. We need to start thinking how we politically want to engage other countries because these things are updating. We now know that the United States is well off. We've known that for a while, but now we need to sort of understand how to support others, in part because we owe it to them. But there's just like vaccination is a sort of way of protecting your family, but also protecting yourself. We owe it to the United States to help everybody else get vaccinated so that variants don't come back to us. If we had a quick, easy, universal rollout, magic wand, and could kind of do this, we wouldn't be having the Omicron conversation necessarily. So there's a kind of self-protection as well as a charity and justice understanding there.
Well, the fact that it's basically airborne or whatever, it's easily transmitted means that you're not living in a bubble just because we're in America. Somebody can get on a plane and bring it in tomorrow. Right. Hannah wanted to know, what are you most scared about or worried about going forward?
I think my answer is complacency.
Yeah.
I think we already sort of see this now, right? Think back to June when we were all so excited because everybody was getting vaccinated and we were able to like take our masks off for the first time. People were going back to work. There were those like 3 or 4 weeks where people were really sort of genuinely back feeling like things were fine. I think Michelle and I might have been the only two hibernating in our basements with our masks on, still telling everybody it was not fine. It wasn't fine, right? And it isn't fine yet. And so I think that worries me because what we're trying to ask people to do is hard, right? Staying, so homeschooling your kids or having to deal with quarantines. I mean, in our school districts around here, they're getting better at testing and they're doing some more things now. But my daughter was quarantined for most of the month of October. Like literally she was in school 2 days out of that month because there were exposures in her classroom. And so what do I do? What do you do with an 8-year-old for 7 hours a day when both parents are trying to work, right? And again, like from a very privileged perspective, like I was able to like make that work. There are lots of people who couldn't make that work, even in our communities. And so I think that complacency part of it worries me in that what that's going to look like because like you said, it isn't about just this one person and their choices. Those choices affect all of us.
I think that's, Europe is looking at lockdowns again, in Austria, England, even Ireland. Sometimes it's, that it's very difficult to sustain, I think, that level of kind of panic, and economics, even though we hate to mention economic, like what are you going to do if there's a virulent, or violent kind of strain out there? But it's hard, I think, to think that this is probably with us on some level, sort of forever. So Meg was saying that, like basically, Michelle, how often do you think it will be a yearly booster then, like you were saying with the flu?
I think I'll do the Anthony Fauci answer, which is,
lovely.
we're not quite sure, but it's respiratory, it's an RNA virus, it changes similar to the flu. Having a booster and a change once a year seems like that would be reasonable, but there are a lot of things that depend upon us getting to that point. When you have the entire globe vaccinated, so you're not going to have pockets where you're passing around, these viruses for people who have the ability to have uncontrolled replication, and that's what leads to mutants. When we have better control over it, maybe we need a booster every few years. I think this is with us. I don't think we're going to eradicate it. The only infectious agent we've ever been able to eradicate is smallpox, and it took 2,000 years to do that. So, like all of our other infections, it will be here. How we return back to normal and how long that takes, I think, that's the $1 million question. People ask Wendy and I all the time, when do you think this will be over? When can I take my mask off and be normal? And I'm like, if I have the answer to that, I'd be a rich woman. We all want to be back to normal, but maybe this is a part of our new normal, at least for a while longer.
Well, to be honest, so I just was on the train over the Thanksgiving weekend, and you're filled with this visceral rage, because you have to fill out the thing 24 hours before you go. Yes, I've been vaccinated. Yes, I will keep on my mask. And the guy across the aisle had his mask, under his lip, not to mind even under the nose. And the conductor said it to him once and didn't say it again. And I just death stared at him for 2 hours, on the way down from Syracuse, because what's so terrible about wearing the mask? And so I will probably keep my mask on in a supermarket or on a plane for the rest of my life. I don't think I'm going to take the sanitizer out of my handbag for the rest of my life. And so those are little things that I think might help, to maybe mitigate some of getting it, I don't know, spreading it, but not getting it, And the last thing I wanted to talk about was the co-option, and this is getting political, of course, of the language. Isn't it so funny to see people, my body, my choice used in this context? Does anybody want to comment on that kind of the dichotomy of where we're at, in how people can be individualistic about this, and maybe a little bit, can we talk about the healthcare workers and how, we're seeing more and more nurses being terminated? What specifically is happening there with people who maybe have access to information that they're not complying? So those are two things. Mm-hmm.
So in terms of the healthcare workers and then sort of nurses, I have to say, for me at least, this was definitely not what I expected to see, with so many people sort of refusing. And at least in talking to the local hospitals, I know that there are, it's in the hundreds, the numbers of people that they are letting go essentially at this point who won't vaccinate. And I do admit that I struggle to understand it a little bit, but I have tried to talk to people and sort of get the perspective on it. And most of the time it has a lot to do with personal choice, right? And feeling like, I get to make my choices. I'm perfectly willing to get tested twice a week. I'm perfectly willing to do all these other things. Which again, I don't know, I guess for me it feels a little myopic in that, yeah, it's your personal choice, but you're also in a hospital with hundreds of other patients and other staff. And I don't know. I think, I don't know that I have my sort of answer. I know Michelle has said a couple times that from her perspective, nurses aren't trained in science in the same way, right? They're trained from a clinical perspective as opposed to the sort of basic science way in which we train doctors and PAs. And maybe that, maybe their understanding of all of this is different as a result.
Well, and I think what's so sad about that is I read, that they're on one ward this week and next week they're on, maternity ward or something. And so the potential for them to be bringing it, you can have a false negative test. There's all these things, and so testing twice a week seems a bit onerous when you could potentially just get a vaccine that is not deadly,
I think such a big issue with a lot of this, and this goes back to the nurses, or just we've become such a selfish society. Yeah. So, I wear a mask to protect you from me. So, a big part of what Wendy and I have both done over the last almost 2 years now is we, on a daily basis, have seen COVID positive people. And when I get together with people, especially older people that I don't see often, sometimes I have my mask on, especially if we've had a really busy week. I'm careful all the time, and I don't want to put other people at risk, and they're almost offended. And I think we as a society, we've become very much, and this goes back to kind of what Barry was saying about HIV and people, no one cared. I think a great book is And the Band Played On, if you don't know the story, to really go and read and see how the gay community was treated. And everyone was like, I don't care, it's not me, it's not me, it's not me. You can't have that philosophy for an infection. I mean, you should never have that philosophy for any infection. But when you're making a decision to not wear a mask, that is something that's so easy, or not vaccinate, to protect those around you. Do you care that little about your fellow man? So I think that is something, as a scientist, I look at the data and I'm like, well, it's a no-brainer. This is what we do. I looked at the data and there's no risk here, or very little risk versus my risk of getting COVID. I struggle with that philosophical, well, I don't care about you. It's only about me. And Barry and I have talked a little bit about this over, every now and again about COVID. And it just, the scientist part of me say it's a no-brainer, and I can't, it's hard to rectify that. But, we all have our own choice, so you have to honor that.
Yeah.
I think I do want to say one thing in defense of nursing, right? Nursing is not necessarily medicine itself is not a science. We do not experiment on individual patients. We use science in medicine to make clinical judgments, but medicine itself is not a science. Even though I think a number of my students who are in public health and think they're going into med school would call themselves scientists. They're not going to experiment, right? So that's a misunderstanding there. I think there's something we should not sort of only say that nurses have a misunderstanding here, or it's somehow a nursing problem about misunderstanding how to respond to COVID, or vaccine hesitancy is only a nursing thing. So I just want to get that out front. There are physicians that are refusing to get vaccinated. They know the science. There are pharmacists that are refusing to sort of get vaccinated. So it's a healthcare thing. Nurses at the front of this pandemic were asked to do bodily care, right? All the intimate need work that nursing is really good at, that allows us to heal after a clinical or surgical intervention. Nurses were asked to do that under enormous pressure, right? They were scared. There were periods where at first we didn't know how this virus was being transmitted. Nurses were still showing up and doing their work. They were doing that bodily care. We asked them to do that once there was certain moments where nurses said they didn't feel like they had the right protective equipment to do that bodily care. And we were asking them to also do it in situations where they were maybe doing double, triple shifts, right? There's a way in which nurses, some of that was, I guess what I'm getting to is to say, there were moments where we're putting nurses in really difficult places. Risky. And maybe saying, maybe they don't really count. Maybe they don't really care as employees. And then once we get the vaccine, we were making demands on them. And it's maybe not that surprising that they said, I don't feel trusted or welcomed or important to my employer, right? Because of how I've been treated over the years. So there's a way in which I don't know that all of this is a scientific misunderstanding. I think some of it could actually be what Maya Goldenberg was saying in her book about, a kind of lack of trust with the institution of medicine. That's different than the lack of trust in the science or the misunderstanding of the science there.
Well, and Barry, they kind of had the lived experience of exactly that, like going into intubated patients, doing everything they had to do in, a mask that they'd worn for 4 days in a row and a plastic bag, because they didn't have proper, shields and things. So part of them might be thinking, sure, I survived it in the worst of it. So what do I need a vaccine for now? So it is, I think, difficult. And Margaret, you had an excellent, you raised a point about, maybe somebody would have to take a 3-day course, like when I was listening to your all of your presentations, it was making me think really like maybe opting out of something like this should be as difficult as it is to get an abortion, in certain states where you have to do courses and have counseling and have a transvaginal ultrasound and go away and think about it for 24 hours. Maybe that needs to be the level of scrutiny that your choice in this medical, and I'm just kind of fascinated by the dichotomy of people who, you know, say in this instance, my body, my choice, but not in another instance, you know. And so when, I can't remember which one of you showed us the statistics, Wendy maybe, you know, that it is a kind of a party affiliation, you know, that are clearly on the other side of the debate for other issues. You know, how can we combat that? Or maybe we can't. I don't know who wants to respond to that. And then we'll probably try to wrap it up. But this, I just find this fascinating. As a historian, I think that's where the crossover with, you know, the sociology, the anthropology, like when did we stop trusting experts, you know? And listen to Jenny McCarthy and her beliefs on autism, you know. But Margaret, sorry, go ahead.
Oh, well, I was going to touch on, I think, a few sort of questions that were raised. I know Hannah said, what do you fear sort of the most going forward? And one of the things that I do fear is this polarization. And I think that it's been building for some time, but I think in this environment, it has gotten really extreme. And I think also what we've been doing to public health and our institutions and our laws that we've been using in public health and our police powers that we've been using for a long time, I think right now we're in a situation where a lot of these precedents are being challenged. And so, you know, again, sort of going back to the idea where we're all in this pressure system, how do we alleviate some of the pressure? I think rather than sort of demand everyone to get vaccinated, recognize that, okay, there is a diversity of opinion. In my opinion, the vaccines are very safe, and I think everyone should get vaccinated. I'm getting my whole family vaccinated. I've had 3 vaccines myself. However, recognizing that there are true fears and there are people who do not want to get vaccinated, and potentially, again, sort of alleviating that pressure through mechanisms to object. Now, again, as I stated previously, they need to be strict, you know, in terms of ways we allow people to object, because ultimately we all need to get to this sort of long-term goal of having a more normal lifestyle, of being able to sort of, you know, be in this all together, right? To get through and get on to the next phase. And so, you know, I mean, it's again, another question with healthcare workers, for example, is initially, I think that the healthcare worker mandate, as proposed by Governor Cuomo, had a religious exemption option, which was subsequently overturned by the new governor. And just an idea of whether there should be some allowances there. There is some history with regard to employer vaccine mandates and sort of then coming and rising up at a similar time as the civil rights movement, where legislation was written with regard to honoring sort of religion, right, as well, and that being a protected class. And so there is a legal concept of undue burden. So I think we need to sort of examine whether someone not getting vaccinated or getting a vaccine exemption on the basis of religion or personal belief would cause an undue burden in certain situations, in certain professions, in certain workplaces. And I think there's nuance to that. I mean, obviously a healthcare worker working with people who are very vulnerable, you know, that could cause undue burden to employers. But if you are, you know, removed from patient interactions, should we allow nuance in that? And I guess that's just sort of where my headspace is in terms of trying to come back to a place where we can sort of meet in the middle again and discuss these issues more rationally.
Well, guys, you know, to be honest, we could go for another hour and a half. I just wanted to say, just as we were starting, or 20 minutes before we came on, a federal judge did block President Biden's nationwide vaccine mandate for health workers. So, you know, I think that's interesting. As Michelle said, I think and it was Hannah's question, you know, the thing that has been so fantastic is that we have a vaccine that, you know, certainly seems to be effective. It seems to have very few side effects. I can tell you, you know, I barely had anything, a little bit of a sore arm, you know, the first day, and that was it, a bit tired. So, you know, I guess the advice is to continue to wear your mask around crowds and, you know, wash your hands. Who knew we were not washing our hands for long enough? That was, you know, happy birthday to you twice. I did not wash my hands that long before this. So I want to thank you so much, the faculty from the Albany College of Pharmacy and Health Sciences. I want to thank the American Museum Alliances, the ILMS and the CDC for this pilot program that we were part of. And, you know, this has been really out of our wheelhouse. We were delighted to do it, absolutely. We are kind of back on track for Irish America during the month. So on Saturday the 4th, we have our Christmas market. On December 11th, we have Triscaeli Christmas concert. Both of those will be held at the Celtic Hall up on New Carner Road. And in fact, we will be doing a reading of A Child's Christmas in Wales up on New Carner Road too on the 8th. Then on the 13th, in our own museum, we have Christmas readings and songs from Ireland and Irish America. And on the 21st, our series, the Centennial of the Irish War of Independence, continues with December 1921. So, you know, thank you guys. This, I think, was very informative. You know, probably we have a lot to still do. And but, you know, I think this kind of conversation, maybe, as Margaret said, needs to continue so that we are trying to meet in the middle and not alienate everybody, you know, somebody. But thank you, everyone, so much. And everyone is saying thank you. You were so informative and interesting, very proud of the faculty. So I leave it there, and good night to you all. Thank you so much for your time. This was great.
Thank you.
Thank you for having us.
Thank you.
Bye. Have a good night.
Great.